Welcome back to the PMHNP podcast, and welcome to this educational seminar, which is an excerpt from our weekly live sessions that are offered by Clarity Education Systems, designed to help prepare master's and doctoral nurse practitioners to sit and pass the PMHNP certification exam. I'm Dr. John Rossi, your instructor and facilitator in these sessions every Wednesday night at 7 p.m. Mountain Time, and this is included in your PMHNP review course package. Okay, so each session delivers rigorous practice questions, comprehensive rationales, and it also has an open forum where enrolled students have the opportunity to address any academic or other professional inquiries that they may be having. It is presented by PMHNPtesting.com, and this seminar is going to focus on critical domains of the psychiatric mental health practice. We're going to have tough, thorough case-based questions, and we're going to explore the diagnostic assessment, the neurobiological underpinnings, and evidence-based interventions to enhance your clinical decision-making and then exam readiness. So let's go ahead and get started with our first question. And it reads, a PMHNP is evaluating a 14-year-old male referred for academic difficulties and behavioral concerns at school. His teachers report that he struggles with organizing his thoughts during abstract reasoning tasks, often acts impulsively, like interrupting others, and has difficulty navigating spatial tasks like map reading during geography lessons. He has no history of trauma or substance abuse, and his parents note a family history of ADHD. During the visit, he appears restless but denies depressive or psychotic symptoms. As a PMHNP, you consider a neurotransmitter imbalance that may underlie his symptoms of impulsivity, spatial challenges, and difficulty with abstract thinking. Which of the following best identifies this imbalance? Option A, serotonin deficit. B, GABA excess. C, mild dopamine deficit. Or D, glutamate hyperactivity. And at this point in the seminars that we have for PMHNP preparation, we would go over the test-taking strategies, dissect this question, really translate it into our own words by identifying the key words, and then coming up with an idea of what we think the answer is before moving on to the actual answers. So if you need a second, go ahead and pause the video and figure out what your answer is and stick with it. Don't change it. Okay, if you chose C, a mild dopamine deficit, that is the best thing to identify the neurotransmitter imbalance that's underlying the patient's symptoms that he's experiencing with ADHD. Okay, so let's go ahead and take a look at why this is true. What's the reasoning behind this question? So our rationale for mild dopamine deficit. So the patient's impulsivity or interrupting others, this reflects reduced dopamine-related inhibitory control in the mesolimbic pathway, and that's your hallmark of ADHD. Spatial difficulties with the map reading, this stems from impaired visuospatial processing, linked again to dopamine deficits in the prefrontal cortex and the basal ganglia. And then we have abstract reasoning struggles. This is because of prefrontal cortex dysfunction, where dopamine modulates executive functions like planning and organizations. Now, the mild qualifier is appropriate in this answer, as severe dopamine deficits would be more aligned with Parkinson's disease, right? So we would cause motor symptoms like bradykinesia, but that's absent in this particular question. Okay, so what are some of the clinical implications of this type of situation? Mild dopamine deficit, we're going to utilize screeners like the Conners rating scale or the Vanderbilt, and we're going to confirm the diagnosis based on teacher, parent, and patient reporting in the assessment. Interventions could include starting a stimulant medication like methylphenidate, and that's going to help increase synaptic dopamine by blocking the DAT, improving attention and impulse control. We also have to do behavioral strategies here. So organizational skills training, classroom accommodations. This is going to help enhance the executive functioning of the child. All right, the PMHNP is going to monitor progress over about 4 to 6 weeks post intervention, and then we assess symptom improvement and medication tolerability. And that's going to be a comprehensive approach. All right, so why are the other questions wrong? Let's take a look at option A, serotonin deficit. Serotonin deficit, this is primarily associated with mood disorders, right? Depression and anxiety, manifesting as low mood, irritability, or sleep disturbances. They don't typically cause impulsivity, spatial difficulties, or that abstract thinking deficit. These are dopamine driven. So, because the patient denied depressive symptoms, ADHD like presentation was there, making this one incorrect. Option B, GABA excess, this would cause overinhibition, and that's going to lead to sedation, slow cognition, and reduced motor activity, opposite to the patient's restlessness and impulsivity. GABA deficits are linked to anxiety and seizures, not relevant here. So his hyperactive and impulsive behaviors definitely contraindicate or contradicts the inhibitory effects that we're seeing from the GABA excess. And then finally, option D, glutamate hyperactivity. This is implicated in schizophrenia or excitotoxicity, something like a seizure. This causes hallucinations, cognitive overload, or motor disturbances. It does not align with the symptoms that we saw in the question, which are, again, dopamine related and ADHD. Okay, so we've gone over some key points with this question and how it's linked to the neurobiology. We have to take into account the family history of genetic predisposition for ADHD, but that's the reason why the mild dopamine deficit is the correct answer here. So, this case really underscores the importance of neurobiological assessment in child and adolescent psychiatry. All right, let's go ahead and move on to our second question. The question reads: a PMHNP is evaluating a 30-year-old male with a history of bipolar 1 disorder and a recent seizure episode, reporting increased mood swings and auditory hallucinations over the past month. He has been non adherent to his mood stabilizer and anti seizure medication, and his family history includes schizophrenia. During the visit, he exhibits rapid speech and irritability with a Young Mania rating scale of 22, indicating a manic episode. The PMHNP considers a neurotransmitter system implicated in the kindling process, which may contribute to his seizures, bipolar symptoms, and hallucinations, and is associated with receptors like AMPA and NMDA. Which of the following best identifies this neurotransmitter and its role? The options are A, GABA, primary inhibitory neurotransmitter involved in mood stabilization; B, glutamate, universal excitatory neurotransmitter implicated in mood disorders and schizophrenia; C, dopamine, key and reward pathways primarily linked to psychosis in schizophrenia; or D, serotonin, central to mood regulation implicated in depression and anxiety. Okay, and the correct answer is B, glutamate. So let's go ahead and break this one down and talk about why answer B is correct. So, the role in kindling. So, kindling involves progressive neuronal sensitivation, okay, where glutamate's excitatory signaling via AMPA and NMDA receptors amplifies synaptic responses, lowering the threshold for seizures and mood episodes. So the patient's recent seizures reflect this heightened excitability, worsened by non adherence to the anti seizure medication. And in bipolar disorder, kindling contributes to mood instability, with 50 to 60% of patients showing increased episode frequency over time. And this is linked to glutamate dysregulation. All right, so contribution to the symptoms here for seizures: the patient's seizure is consistent with glutamate's role in excitotoxicity, where excessive NMDA receptor activation triggers neuronal hyperexcitability. Bipolar mania, rapid speech, irritability, YMRS score of 22, that's going to indicate a manic episode. And again, that's driven by glutamate in the prefrontal cortex and limbic system. disrupting mood regulation. And then finally, the hallucinations here. Auditory hallucinations suggest psychotic features, potentially linked to the NMDA receptor dysfunction, where glutamate imbalance in cortical striatal circuits mimic schizophrenia like symptoms. All right. So, what is the receptor association here? The AMPA and NMDA receptors, they mediate glutamate's excitatory effects, with AMPA driving fast synaptic transmission and NMDA supporting synaptic plasticity. So, their dysregulation and kindling, seizures, and psychosis directly ties to the patient's presentation. All right. So, why were the other questions wrong? Let's go ahead and move on to option A. So GABA is the primary inhibitory neurotransmitter, and this counterbalancing glutamate to reduce neuronal excitability and is targeted by mood stabilizers and some benzodiazepines as well. However, GABA is not directly involved in the kindling process, which is driven by excitatory mechanisms, nor is it linked to the AMPA NMDA receptors or schizophrenia's hallucinations. So the patient's seizures, mania, and psychosis are excitatory phenomena, and that's inconsistent with GABA's inhibitory role. Option C, dopamine. So, dopamine via D2 receptor hyperactivity is implicated in schizophrenia psychosis, right? Things like hallucinations, and may contribute to bipolar mania. But dopamine is not the primary neurotransmitter in kindling or seizures, nor is it directly associated with AMPA, NMDA receptors. So, while relevant, to the patient's hallucinations, dopamine does not fully explain the seizure or bipolar mood swings, which are, again, glutamate driven. All right. And then finally, option D, serotonin. Now, this regulates mood and is implicated in depression and anxiety, but it is not involved in the kindling process, seizures, or schizophrenia's hallucinations, nor is it linked to that AMPA and NMDA receptors. So the patient's manic episodes, seizures, and psychosis, not serotonin driven, making this one incorrect as well. Okay, so in this question, we learned about glutamate's role in the kindling process, seizures, bipolar mania, and psychotic symptoms. We learned to recognize kindling, link symptoms to the neurobiology, and then prioritize adherence. All right, and so let's take a look at that prioritization um, adherence here, because that's going to be an important part of your role as the PMHNP. So we have to ensure that medication adherence is spot on, right? So we have to reinstate that anti-seizure, for example, like lamotrigine, which inhibits glutamate release, and mood stabilizing medication like lithium to reduce the excitability and stable mood. All right. And then we need to address that psychosis where we initiate an antipsychotic like olanzapine, for example, to target hallucinations with this goal of treating that bipolar psychosis. All right. And then we got to monitor the progress, regular follow up, 2 to 4 weeks. We need to reassess the YMRS scores, seizure control, and psychotic symptoms during our comprehensive management and assessment of the patient. All right. So that's going to finish off that question. Let's go ahead and move on to our third case. Okay, so this is going to shift focus to systems level responsibilities of the mental health nurse practitioner. So the question reads: a PMHNP is leading a quality improvement initiative at a psychiatric outpatient clinic to enhance patient satisfaction and treatment adherence among adults with bipolar disorder. The clinic has faced challenges with long wait times, inconsistent follow up care, and variable patient outcomes. To systematically evaluate and improve the clinic's performance, the PMHNP applies a healthcare quality framework that assesses the clinic's resources, care delivery methods, and patient results. Which of the following best identifies this framework? Option A, the Plan, Do, Study, Act, or PDSA cycle. B, Six Sigma methodology. C, Donabedian model. or D, balanced scorecard approach? Okay, and the correct answer here is going to be C. So in this case, we're really looking at how the PMHNP's role in advancing healthcare quality within a psychiatric setting is critical to the competency and improvement of patient outcomes. So the PMHNP must select a framework that systematically evaluates and addresses systematic challenges in a psychiatric outpatient clinic serving adults with bipolar disorder. So let's go ahead and analyze the clinic issues here. We've got long wait times, inconsistent follow up care, variable outcomes, and then quality improvement initiatives that need to be put into place. So the PMHNP is going to seek a healthcare quality framework to assess those resources that are inside the clinic, the care delivery methods, for example, like follow up protocols and patient results, satisfaction scores, and adherence to treatment plans. So, why is C correct? Let's go ahead and talk about the Donabedian model. This was a foundational framework in assessing healthcare quality through three interrelated components, and that's going to be structure, process, and outcome. So, in the context of this case, this model enables PMHNPs to systematically evaluate a clinic structure. For example, we're going to address long wait times through resource allocation, processes where we look at standardizing follow up care protocols, and outcomes where we are going to improve patient satisfaction and adherence. And so, this framework is widely adopted in healthcare settings for its comprehensive approach to quality assessment and improvement. Okay, so let's look at what we can do as the PMHNP if we apply this Donabedian model. So we optimize scheduling systems to reduce long wait times, implement electronic booking options, and increasing staff availability in order to address the resource gaps. And then we can look at the process by standardizing follow up care protocols like mandatory post appointment check ins and things like care coordination planning. And that's going to help ensure consistency. And then we're going to look at the outcomes. So we monitor patient satisfaction. We're going to use validated surveys like the patient satisfaction questionnaire and treatment adherence like medication refill rates, setting a benchmark for improvement within the clinic. So, this systematic approach identifies specific interventions such as hiring additional staff for the structure, developing follow up guidelines for the processes, and tracking satisfaction scores. So, the model's comprehensive scope is going to help us make sure that all aspects of care are addressed. Okay, so let's take a look at the wrong answers and why they didn't fit into it. So, option A, the PDSA cycle, this is a quality improvement method that involves um, testing of challenges, right? Plan, do, study, act, not a framework for assessing quality. So while PDSA could be used to implement changes, like testing a new scheduling system or something like that, it does not provide a structured evaluation of structure, process, and outcome. That's what's required here for the systematic assessment described. All right. PDSA focuses on action steps and not comprehensive quality analysis. All right, option B, Six Sigma. This is a data driven methodology which is really aimed at reducing variability and defects, primarily in manufacturing or large scale healthcare systems where we use statistical tools. Things like the DMAIC or the Define, Measure, Analyze, Improve, Control method. All right, it's not a framework that focuses on structure, processes, or outcomes. It really emphasizes on error reduction, so minimizing medication errors, for example. So this focus on the error reduction, it's too narrow for the comprehensive assessment of clinic resources, care delivery, and then the patient satisfaction. Option D, balanced scorecard approach. So this evaluates organizational performance across financial, customer, internal processes, and learning growth perspectives, primarily in business settings. So while it includes outcomes, um, it is non-specific to healthcare quality assessment, and it does not focus on things like structure and processes like we see in our correct answer. So it's broad. business-oriented approach, less relevant to a psychiatric clinic's needs. All right, so with this Donabedian model, we learn about structure, how to apply it to psychiatric care, and then how it leads to quality improvement. And we also differentiated between those frameworks that were presented in the question. So this case really it demonstrates your role as a PMHNP in advancing healthcare quality through systematic frameworks, and that is a core responsibility and a core role of the nurse practitioner. All right, let's go ahead and move on to our fourth question. This is going to emphasize the application of psychological theories to address neuropsychiatric symptoms in a pediatric patient. The question reads: a psychiatric mental health nurse practitioner is working with a 16-year-old male for an outpatient psychiatric clinic who presents with social anxiety, reporting intense fear of public speaking at school. He describes watching a confident classmate give a presentation and wishes he could, quote, be like that, close quote, but doubts his own abilities, stating, quote, I'll mess up if I try, close quote. The scores, 14 on the social phobia inventory, or the SPIN, indicates moderate social anxiety. The PMHNP considers a theoretical framework that integrates self-efficacy and social learning, focusing on how behavior is shaped by personal beliefs and observed influences to guide the therapeutic approach. So, which of the following best identifies that type of framework? Option A, Albert Bandura's concept that behavior is the result of cognitive and environmental factors. B, Eric Erickson's theory of psychosocial development. C, Aaron Beck's cognitive theory of disordered thinking. Or D, B.F. Skinner's operant conditioning model. Okay, and in this case, the correct answer is going to be A. This is Albert Bandura's concept that behavior is a result of cognitive and environmental factors. So, what we're looking at here is applying a psychological theory to address those social anxieties for that adolescent. And that's going to be a critical aspect of neuropsychiatric care for this population. So, we have to select a theoretical framework that integrates that self efficacy and social learning into the therapeutic intervention. So he has an intense fear of that public speaking, social anxiety. He's observational learning, right? We're looking at a confident classmate and wanting to be like that. We look at the low self efficacy, thinking that he's always going to mess up if he tries and he'll never be able to succeed. We do have a SPIN score of 14, so there is evidence of moderate social anxiety. And the patient's adolescent developmental stage emphasizes this peer influence and identity formation. And that's why making social learning and self efficacy really relevant in this type of question. Okay, so what is the rationale for this response, the Albert Bandura's concept? It is supported by the fact that it aligns with the patient's presentation. First, that self efficacy, that statement that the patient made about messing up all the time, that's a cognitive factor that's central to Bandura's theory. That's going to drive avoidance of public speaking. Then there's the social learning, his desire to be like a confident classmate. That's going to indicate observational learning. So where the model behavior based on a peer's successful presentation within an environmental influence. And then behavioral outcomes, his social anxiety, that SPIN score of 14, and fear of public speaking. This is a result of the interplay of these cognitive, self doubt, and environmental peer observation factors. And that's consistent with reciprocal determinism. Okay, so what do we do? What's the application to the therapeutic approach in a case like this? So we're going to apply that Bandura framework, and we're gonna build confidence, increase self-efficacy of social anxiety by utilizing that particular framework. And then there's the leverage modeling. So we're going to incorporate positive role models. So role playing with a supportive peer or therapist, and that's going to help demonstrate effective public speaking. And then cognitive interventions, we're going to address negative beliefs through cognitive restructuring. That's challenging the I'll mess up with evidence of past successes. And that's going to help integrate exposure to reinforce behavioral change. All right. So What's up with these other questions? What's wrong with them and why are they wrong? First option was B, Eric Erickson, right? So, Erickson's theory, this focuses on developmental stages like identity versus role confusion for adolescents, emphasizing the psychosocial conflicts. While it is relevant to the patient's adolescent age here, it does not address self efficacy or social learning through the observation, nor does it explain how cognitive and environmental factors shape behavior. So it's too broad for the specific issue of social anxiety and public speaking fear. Okay. Option C, Aaron Beck's cognitive theory, this emphasizes distorted thinking patterns, so negative automatic thoughts and disorders like anxiety for focusing on this cognitive restructuring. While relevant to the patient's negative beliefs, the I'll mess up statement, it does not incorporate, again, social learning or cognitive and environmental factors. Okay, and finally, option D, B.F. Skinner's operant conditioning explains behavior through reinforcement and punishment, focusing on environmental consequences. So it does not account for cognitive factors like self efficacy or social learning through observation. And that's critical to the patient's belief in his ability and peer influence. Okay, so in here we learned to understand Bandura's framework for self efficacy, observational learning, and reciprocal determinism. We apply it to social anxiety. We tailor it to our adolescents by utilizing CBT and social learning components. And then we differentiate those theories so to make sure that we choose the right one, which is, in this case, Albert Bandura's concept. All right, great job. So let's go ahead and conclude with our fifth case here, where we're going to focus on the application of developmental psychology. So the question reads, a PMHNP is evaluating a 5-year-old boy whose parents report concerns about frequent tantrums and difficulty sharing with peers at preschool. They describe him as demanding immediate rewards, such as insisting on toys or snacks right now, and becoming upset when told to wait. He has no history of trauma, and his developmental milestones are otherwise age appropriate. During the visit, he interrupts conversations to demand attention, showing frustration when redirected. So the PMHNP considers Sullivan's stages of interpersonal development for childhood, ages 2 to 6 years, as the key task that, if not achieved, may contribute to these type of behaviors. Which of the following best identifies this developmental task? Option A, forming intimate relationships. B, delayed gratification. C, establishing a sense of trust. Or D, developing a sense of industry. All right, and our correct answer here is going to be B, delayed gratification. All right, so this shows us our role in applying developmental theories to assess and manage behavioral changes in this particular population. So we have to identify the developmental task from Sullivan's interpersonal theory that, if not mastered, is going to explain why the child's behaviors, guarding and guiding his specific actions are related to this particular developmental stage. All right, so we have behavioral concerns here that are presented by tantrums, difficulty sharing with peers, demanding immediate rewards, behavioral observations that include things like demanding attention and getting frustrated when redirected. And that's suggesting a need for this instant gratification. And then context here, there's no history, no age appropriate developmental milestones, and we're in a preschool setting. So these behaviors are going to suggest a developmental challenge rather than a psychiatric disorder. So let's remind ourselves of Sullivan's interpersonal theory. So this hypothesizes that personality develops through social interactions across distinct stages, with each stage defined by a key developmental task. So in childhood stage, the 2 to 6 years, the primary task is learning delayed gratification, and that's going to include postponing immediate desires. So tolerating delays and rewards, right? Waiting for a turn to achieve a social goal. Frustration tolerance, managing those emotional distresses with desires, um, that are well, we're gonna defer those desires in those situations, and that's going to help foster this self-control that we're looking for. And then cooperative interactions, engaging with peers, parents, and authoritative figures through sharing and turn taking, and that's going to help establish social harmony. So failure to master delayed gratification is going to result in behaviors like tantrums, impulsivity, and difficulty sharing. All right, so what do we do in this case? The PMHNP is really going to need to involve parents here. So, parental guidance. We need to collaborate with parents to model delayed gratification using reward systems with gradual delays. So, earning a toy after completing a task. We also want to incorporate play therapy to facilitate social skills development through structured play, like taking turns during a game, and that's going to help improve cooperation. And then finally, behavioral strategies here. We're going to implement positive reinforcement. So, praise for waiting, right? And this is going to enhance frustration tolerance and then reduce tantrums. We do need to monitor the patient monthly for about 3 to 6 months and then assess that behavioral progress. And then using parent and teacher reports, we're going to track how the child has been sharing and how many tantrums the patient's been having. All right, so let's look at those wrong answers here. Option A, forming intimate relationships. This is a task of Sullivan's adolescent stage, 12 to 18. And this is where individuals develop close, intimate bonds with peers. So this 5-year-old's challenge centers on the self control and sharing, not intimacy, which is developmentally inappropriate at the childhood stage. Option C, establishing a sense of trust. This does align with Sullivan's infancy stage, the birth to 1 year, where constant caregiving is going to foster the trust. So the child's tantrums and impatience, this reflects issues of delayed gratification, not trust. And then option D, developing a sense of industry. So this developing a sense of industry, this is a task of Sullivan's juvenile stage, that would be ages like 6 to 9, or Erickson's industry versus inferiority stage, that 6 to 12ish range. And this focuses on competence and achievement. So the 5-year-old in his childhood stage and his behaviors, this is going to indicate a struggle with, again, that delayed gratification, not industry. So, in this question, we've learned to understand Sullivan's theory, specifically in the childhood stage, 2 to 6, where we focus on delayed gratification. We linked behaviors to development, so tantrums, impatience, difficulty sharing. This reflects failure to master delayed gratification. And then we applied targeted strategies like parental modeling, play theory, and reinforcement to promote that delayed gratification in preschoolers, and then differentiate between the different stages. All right, so good questions involving theory, involving application, and really kind of focusing a lot on the adolescent and childhood population here. Um, but that's going to bring us to the end here of this particular seminar component of the weekly live sessions that are offered by Clarity Education Systems. Again, helping you prepare for and pass your certification exam. So we've looked at these 5 case studies and questions. We addressed dopamine deficits in ADHD, glutamate's role in bipolar disorder and seizures, the Donabedian model for quality improvement in bipolar care, Bandura's social learning theory for social anxiety, and finally, Sullivan's delayed gratification task and childhood behavioral challenges. So each case helps enhance your clinical and systems-based competencies. And this is going to help equip you with ways to excel in the neuropsychiatric care, and then obviously achieve and pass for your certification. All right, so at the end of our Wednesday live sessions that are held at 7 p.m. Mountain Time, we transition to an open forum where currently enrolled students, they're going to address any inquiries that are related to their academic semester, the review program itself, study materials, practice questions, or any other relevant topics that they want to go over. And this forum is accessible via a live link on the PMHNP student portal for the enrolled students. And this is going to help foster collaborative environments for professional growth, which is really important and is often missed in a self-paced program, or if you don't go to the live conferences. So, for those not yet enrolled, we invite you to explore www.pmhnptesting.com to learn how Clarity Education Systems can support your certification journey. So, as we close, I offer 2 reflections to inspire your continued pursuit of professional excellence in psychiatric mental health nursing. First up, don't practice until you get it right. Practice until you can't get it wrong. And that's an anonymous site here. So this reflection emphasizes the value of persistent, deliberate practice in achieving mastery. So your engagement with complex cases, such as applying Sullivan's theory or navigating glutamate's role in bipolar disorder, requires this repeated effort to internalize clinical knowledge and skills. Research on expertise development indicates that internal clinical understanding and consistent practice with feedback and refinement, this is going to help improve performance by 20 to 30% in these high skill professions like nursing. So by practicing until mastery is second nature, you're going to prepare to deliver exceptional care and confidently address the certification examination's challenges. All right, then finally here we have, and I love this quote. It's kind of a stretch to put it into like the motivational thought here for certification, but I just love it so much I had to include it. Kindness is a language that the deaf can hear and the blind can see. And that's by Mark Twain, and I love it. So his insight here underscores the universal impact of kindness, which is a cornerstone of mental health treatment, right, and nursing. Your compassionate approach to patients, whether addressing the social anxiety or behavioral challenges, this is going to foster trust and healing. So studies on therapeutic alliances, they demonstrate that empathy and kindness enhance patient outcomes by anywhere from 15 to 25%. That's huge. This is going to strengthen adherence and satisfaction in their psychiatric care. So as you advance towards certification, let kindness guide your interactions, creating meaningful connections with patients and colleagues alike. All right, we look forward to engaging with all of our enrolled students at our next live session this coming Wednesday at 7 p.m. And you may bring your questions to the PMHNP student portal at that time. For further information, again, please visit PMHNPtesting.com. Your commitment to this rigorous preparation is commendable. You're doing great things, and we are confident in your path to becoming a psychiatric mental health nurse practitioner. All right, until our next session, continue your pursuit of mastery and compassion. Bye-bye.